name's Tom Buttel. I'm a 59-year-old man and I have osteoarthritis. I've had it, I think, since I was about 25, because that's when I noticed changes in the morphology of my joint, and also the pain became really chronic around that stage. I've been helped by the work that Professor March and Professor Hunter have done, but I didn't realise I was actually helping myself before I realised that was a job that I had. So I had my surgery. I hurt my knee when I was 17, and then I had surgery 18 months later, and in that time I must have had about 20 dislocations. And I needed lateral and medial ligament repair and a total meniscectomy. And my surgeon said it was a miracle I didn't do my ACL. So I guess I'm lucky in one sense. When I was recovering from, I had plaster for about 4 months, and I used to take myself down to Balmoral Beach, and I saw these guys running along the beach, and they looked really fit. And I said to one of them, mate, what are you doing? He said, oh, we do the contract garbage collection for Mossman Council. And I thought, that's the job for me. So when my plaster was taken off 4 months later, I rang the boss, no mobile phones in those days, and I actually got the job. And I did the job for 21 years. And that photo was I was launching in my own private practice. And one of the psychiatrists that I used to say hello to on the beach, John Ellard, he's in heaven now, but he said, Tom, I'm going to get you on the front of the Mossman Daily. And he did. And that was page 3 of the, I think it was the Daily Telegraph or the Daily Mirror. But what I realised in doing that job, I did it when I was a student, I did it during the week and always also on the weekend. But there was a lot of going up and down steps. There was walking on the beach. And it was a lot of the exercises that I've done through the program. So I'm doing the osteoarthritis management program. And I realised that that job replicated a lot of the exercises that I'm actually doing with the physios. So it was sort of accidental that I came to that. Now the next one, if we can get it to happen. Oh, I've had medication, and I actually remember, this is how much I've had, not much medication. I've had medication for 6 weeks in the last 35 years. I took Cerebrex for 5 weeks, and last year I had a fall and I was prescribed, help me David, it's an anti-inflammatory anyway, and I took it for 6 days. I was told to take it for 6 days, and that's all I took it. So my pain relief, I've used other mechanisms. And one of the ones I've used, and there's probably no evidence base, but one of the ones I've used is I've been meditating for 25 years. And I believe I've developed something in my mind where I can switch chronic pain off. When I had my fall, that was acute pain. That was a different story. I was in agony. But the chronic pain that other patients talk about when they're sleeping or just, you know, sedentary, I don't get that. So at the moment, I can't tell you which is my bad knee. If I was to go for a 10-mile run tonight, I'd know tomorrow. And when I do the osteoarthritis management program, there's a multidisciplinary team. There's you know, specially structured exercises, and sometimes that does generate some level of pain, but it's what I call good pain. It's different to the other sort of pain. So this was a book that I read when I was about 19. My sister actually got it for me, and it was by Ainsley Mears. Has anyone heard of Ainsley Mears? He was a man well ahead of his time. He was a psychiatrist, but he'd studied a lot in Eastern medicine as well. In fact, his son is Professor Russell Mears, who's Professor of Psychiatry at Sydney University. So that book really helped me. And this one, I find that as I'm getting older, I'm finding, one, my muscle mass is reducing. I can actually feel it. And also it's more of a challenge to lose weight. And I know that by losing weight, that's going to help my osteoarthritis, so I don't want to gain weight. And unfortunately for me, I've got some comorbidities. So I've got diabetes 2 and I've got hypertension. So they're an added challenge to all this. But certainly I've been helped by the research that these people are doing, and I'm very grateful for that. And I just think to myself that come this Saturday, it's the 50th anniversary of man's landing on the moon. So I was a bit of a science nerd when I was a kid. So I remember watching it, I think I was about 9, in fascination in the black and white TV. But it's interesting that we've got terms like the space race, you know, and, you know, walking on the moon, and, you know, one small step for man, one giant leap for mankind. Obviously, Neil Armstrong didn't have osteoarthritis. But the challenge is that if we can go... In 1903, the Wright brothers flew for the first time. 66 years later, we went to the moon. 66 years, not a long time. So if we could apply the same sort of attitude to, you know, curing osteoarthritis, maybe we can do it in less than 66 years. That's my hope. But look, thank you. I thank Professor March and Professor Hunter for inviting me. I always feel honoured when I'm attending one of these events. So cheers.
So Chris Little is my name. I'm now going to take you back from what Tom was talking about as the patient all the way back into what we do here in this building, which is basic science research. So I'm the basic science nerd to match Tom's nerd watching the space landing. And we're the same age, by the way, Tom. And so, no, it is a male thing, obviously. Thank you. So I'm just going to don't bother reading those. That's exactly what David and Lynn told you about the burden of musculoskeletal disease. It's an enormous problem, leading single cause by far of disability in Australia. And for the three major diseases, the chronic diseases that we're dealing with here, osteoarthritis, intervertebral disc disease and back pain that Manuela talked about, and tendinopathy, there's no cure. And I think that's a terrible blight on the system, that what we're doing now is managing as best we can and developing management tools to help someone like Tom, but there's no cure for these things. And as Lynn said, that's what we're aiming to do. We should aim high and be trying to cure these diseases. So what do we do in the Raymond Purvis Bone and Joint Research Laboratories, which is the laboratory that I run? I'm part of the Department of Orthopaedics. I'm actually a veterinarian by training. I dealt with osteoarthritis in racehorses and in dogs and in cats. And I now work here at Northern Sydney Local Health District, which is not a blight on the healthcare system. It's because I do basic science research. And what we're trying to do is to define the cellular and molecular mechanisms that drive these disease processes. My main interests are in those three diseases, osteoarthritis, tendinopathy, and intervertebral disc disease. I'm going to focus on osteoarthritis today. And understanding the cell biology, the molecular biology, that science nerd stuff as to how we go from one step to the other. So I think of research that I do in this two-pronged approach, where I might start, in this case, with a healthy joint. Let's see if I can get that laser pointer to work. I start with a healthy joint and I end up with a diseased joint. And you don't do that overnight. You don't go to bed one night with a really healthy joint, wake up in the morning with osteoarthritis. There's a stepwise process that you go through over years to go from that healthy joint down to that diseased joint. And every one of those steps along that pathway, every one of those cellular and molecular steps is a potential point for us to intervene. And if we understand those and know where they are and can intervene in those, we can hopefully stop the disease process. And if we go early enough with those green arrows, perhaps we can reverse it. That's the cure phase of this. So that's one arm of basic science research. How do I go from healthy down to diseased? And if I understand that really well, then I can start coming up with cures for it. The other side of that is if I've got a diseased joint, I can try and repair that. And that's some of the stuff that's also important research. It tends to not be the research that we do, that I do, but that's how can I build a better joint? How can I have a better joint replacement? How can I use stem cells maybe to rebuild that joint? We do some of that work, but most of ours is in that other arm over there. And so we're interested in that, in the cellular molecular mechanisms, and how do we translate that into then helping people? So that's in this phase of discovery and translation. We do a lot of preclinical animal models. I told you I'm a veterinarian, and what I do a lot of is animal models of disease. We can talk about the ethics afterwards over a drink if you'd like. But I have models for these diseases that we can understand those processes and we can test new therapies to see if we can reverse it. And that's the first stage in getting these things into people. So we have this bedside to bench approach. I sit and I talk with David, I talk with Lynn, and I talk with Manuela, and they tell me what their problems are. And I say, how can we investigate that? So we take it from the bedside, I look at it on the bench, and I come back to them and say, I think we could do this, and they might try it and say, that didn't work. So it's this cycle, but it starts with the patient. Just very quickly, I'm not going to go through these. We have a bunch of research in osteoarthritis. So this is our discovery research projects at the moment that are ongoing. Some of them funded by NHMRC and ARC and other places. And the next one is in our translational research slide, which is where we're also doing work with a lot of companies. In those animal models I talked about, we test their therapies and see, as the first stage to translation, can we stop the disease or reverse the disease in our animal models? I'm going to give you one example of the stuff we talked about, just give you one. I'm going to give you about 30 seconds worth of 8 years worth of research here, which is one of the things we're interested in osteoarthritis is inflammation. So we used to think of osteoarthritis as this wear and tear disease. We just grind it down, and that's not true. It's a biologic process where the cells in the joint are responding to altered loads, and that happens. So we're interested in the fact that you have inflammation in osteoarthritis, and in our animal models we looked at that. So this is just showing you some data here with looking at joints with different diseases here, and we looked at the inflammation, we looked at the cells in those joints, and for the first time what we can do in an animal model that we can't do in people is to have a joint injury that doesn't cause osteoarthritis versus a joint injury that does. We can match those side by side and say, how are they different? And it turns out they're very different. So I can have exactly the same injury that will and won't go to osteoarthritis in my mice, and I can look at the cells in there and they're very different. And if I then do some more clever work rather than just counting the cells and look at what type of inflammatory cells they are in there, and I can break them down into the type of cells that we normally see associated with wound healing. And I won't go through the data in detail here. Those two lines, I think you'll agree, overlap. That's the cell type we used to think was involved in osteoarthritis, the macrophage, this particular cell type. Exactly the same in our joint injuries that do and don't induce osteoarthritis. When we looked at the cells that are associated with rheumatoid arthritis, so in the autoimmune disease, which osteoarthritis isn't, this is a joint injury model, suddenly they were very different. So this model that was driven by joint injury, the lymphocytes, this particular immune cell, was different now in the injury that doesn't induce osteoarthritis. So we said, let's go back to the patient. Do we actually see that in people? So exactly the same sort of stuff that Lynn's looking at here, we went to colleagues in the US because they had some samples. And those same cells were increased in patients that had a meniscal injury in their knee joint. They were higher earlier after injury. And the higher they were, the worse the patient's pain was. So it seemed to be associated with clinical symptoms. We then took some joint tissue from patients at joint replacement for osteoarthritis, and we took those cells out in the laboratory. And when we did that, we actually reduced the enzymes that break down cartilage. So not only were they potentially associated with pain, these cells that we found might be driving the destruction of the joint. So we said, let's go back to our mice one more time. What happens in our animal model if we take those cells out? So we used an antibody and took those cells out, and if we took them out really early, this first one here in the first week after injury, we could stop the long-term disease. But if we waited for a while, it didn't work. So we've now found a way, at least going back and forth from patients to people, to our mice, where we can diagnose the disease, we can start differentiating them, and we might be able to stop you getting osteoarthritis in the future. So I'll finish there and tell you that what we're trying to do is to improve this pathway of discovery through to patients. That silly slide picture on the right there takes about 20 years to go from a discovery to a drug for someone, and it has about a 5% success rate. Terrible. What we're hoping to do is improve that with some of our models. And so our vision here in the Colling and in this building is to unite that discovery into reality, coming together for patient care. I will thank the people that actually do the work. I'm just standing in front of you. And I'll stop and hand over to the next person, David.
I want to start by telling you a little bit about our strategic direction and where we come up with a plan as to what type of research it is we're going to do, and then tell you, at least to give you a brief flavor of the type of research that's currently going on. And again, it's all being done to inform clinical practice, to make it different to patient care. So what is osteoarthritis? You've heard many different guises of this, but essentially it's a disease of the whole joint. So any tissue within what we call the synovial joint can be affected in osteoarthritis. Historically, everybody thought this was about cartilage, but it can affect any tissue there. But most importantly, it's an illness. It presents with a person complaining of pain and limited function as a consequence of the changes within the joint. It's incredibly common. 1 in 8 adults in the Western world are affected by this condition. I'm just talking about knee osteoarthritis. Hand osteoarthritis, if anything, is more common for those people that are affected by this. So it's incredibly prevalent. As mentioned, it's incredibly disabling. So for 2 in 3 patients, the last time they were pain-free was over a year ago. So this is some data from Arthritis Australia, Andrew Mills is over here, that they came out with a couple of years ago. Incredibly disabling. 2/3 of those that are affected are of working age. So this isn't just older adults. And the importance of that is that it has a big impact on premature retirement. Between back pain and osteoarthritis, These are the leading causes a person retires prematurely from the workforce. And that has obviously huge personal implications, but then also huge socioeconomic implications. So for anybody who cares about our economy, about 0.5% of our gross domestic product every year is related in some way, shape, or form to musculoskeletal disease, both direct, but very importantly, indirect costs, so costs related to underemployment and absenteeism. So this has huge economic implications. So what do? So one of the things we started about 5 or 6 years ago, collectively as an Australian community of people who are involved in osteoarthritis, is started to set out research priorities. So what should we be focused on? And this is the last research priority setting exercise we did back in 2017 that involved a number of consumers here in the room, a number of health professionals and researchers in this space. With the intent, we wanted to identify what it is that as a community we should be focused on. Much of what we do currently for treatment involves things that are hard for everybody. Exercise, weight loss. A lot of people don't like doing that. So adherence to that is one of our huge clinical challenges. So we wanted to focus very much on how we improve treatment adherence and behavior change. The holy grail for many of us, Chris, myself included, is looking at an area we call disease modification. So as patients with osteoarthritis, you might be experienced with the concept of symptom modification, so relieving your pain and improving your function. But our holy grail is doing that in addition to improving the disease. So that's an area we're actively pursuing, in addition to thinking about opportunities for prevention. So for knee osteoarthritis, the 2 biggest modifiable risk factors, overweight and obesity and joint injury, account for 75% of a community's risk of developing osteoarthritis. And they're both modifiable, and as a society, we do little, if anything, about it. So lots of opportunity to change that. So as a group, I have the privilege of chairing a larger group of people. We focus, well, you look at this slide and you probably say you don't focus, David, but we have a broad clinical research initiative that includes looking at disease and pain mechanisms, biomarker development, particularly around imaging. We do a number of different clinical trials, and I'll give you a sense of some of those in a moment. Very interested in the delivery of health services and how we can influence patient care, and also do quite a lot of advocacy and policy work. One of the trials that we've recently completed that was run by Sarah Menezes and Vicky, who are wonderful people within my group, looked at a combination of therapies for people with base of thumb osteoarthritis. For anybody who's got hand osteoarthritis, this is one of the most disabling joints that can be affected. So we tested a combination of a splint, topical anti-inflammatories, hand exercises, and joint protection advice compared to joint protection advice alone, and found that to be very effective both at 6 and 12 weeks in terms of relieving pain and function. And we're now in the process of developing the publication with the intent to disseminate that. An NHMRC funded project grant that we've recently again completed was looking at a concept we call femoroacetabular impingement. So long word, but essentially there's a structure within the hip that when a person flexes and adducts their thigh, that little lump is not meant to be there. It happens in about 20% of young adults. It's more common in people that do flexion adduction type sports, so martial arts, kicking type sports. And it's thought to account for about 80% of the reason why a person might develop osteoarthritis in the hip. What we've done here is we've compared surgical removal of that bump to physiotherapy and looked both at compositional imaging, so this is proteoglycan on MRI. We've also looked at contact stress and area on gait analysis with the intent to see, does the surgery make any difference compared to physiotherapy in a randomized controlled trial setting? Another trial that we're doing, which I think is incredibly informative, again, to patient care, is a thing called the Pathway trial, which I'm doing again in collaboration with Manuela and a number of other people in our group. We know that inpatient care following spine and knee replacement surgery is incredibly controversial for rehabilitation. For many private insurers in the room, it's the bane of their existence. For the private hospitals, it's their livelihood. So what we're looking at here is to see, can we deliver through remote disruptive technology rehabilitation strategies and techniques so that a person can optimize their recovery as an outpatient at home? So we're looking at this with a combination of various devices, including health coaching, monitors to monitor steps and sleep, activity and movement tracking, but again, remote delivery of rehabilitation to see if we can optimize rehabilitation for a person following knee replacement and/or spine surgery in their home environments. And this is sponsored by the Ramsay Foundation. For those of you who are very interested in novel means of pain relief, a trial that we've recently just completed is the use of a topical cannabinoid. So this has very little, if any, THC, for those of you who are big fans of THC. So it has none of the psychoactive effects and appears to be very effective in relieving pain. So this is applied twice daily to the upper arm, and it was a randomized trial for people with symptomatic knee osteoarthritis, and again, appeared to be quite effective in that context. A recently funded project grant from, again, the NHMRC, which will be starting later this year and doing in collaboration with Chris Little and a number of other people in the room, is looking again at a very controversial area, the use of intra-articular stem cells for knee osteoarthritis to see if we can modify both symptoms and structure of this disease long term. And I'll tell you about that in 5 years' time once we've completed the trial. So don't hold your breath. Okay, but again, really exciting opportunity. And again, an area that we're actively involved in is the development and testing of a number of disease-modifying agents. This is a list of some of them, but there's a number of them that are in late stage, what we call phase 3 trials, so soon to go to the regulators, hopefully for approval, to see if it can make a difference to patient care. And a number of these agents are demonstrating quite clear changes that demonstrate improvements in structure and symptoms. So it's a really exciting space to be involved in. For the consumers in the room, and again, a big plug to Arthritis Australia, a resource that we developed a number of years ago called My Joint Pain, freely available, provides individual tailored management programs, wonderful educational videos, means to monitor their own disease, that's freely accessible to anybody in the Australian community, that we've tested and evaluated and appears to be quite effective at doing a number of different things for people with osteoarthritis. So it's out there, it's a wonderful program, and hopefully a wonderful resource to help inform people about their disease. Last year, hopefully in closing, we developed what's called the National Osteoarthritis Strategy. So the vast majority of people out there in the community that have osteoarthritis receive either fragmented, inappropriate, or low-value care, or all three of the above. So we want to change that. And one of the ways we want to change that is by advocating for better care, both in terms of preventing people developing the disease, improving management for those that live with the disease, but also improving rational care surgery for those people with later stage disease. And so this is an area we're actively involved in advocating for. I have the privilege of working with a wonderful group of people who do all of the work, and I stand out here and get all of the accolades for the wonderful work that they do. But it's a privilege to lead them, and I also have the privilege to collaborate with a large group of people, both nationally and internationally. I get a lot of support from Arthritis Australia, the National Health and Medical Research Council, and NIH, and I work closely with the clinical team, the Institute of Bone and Joint Research team, and my own immediate research team. But again, all accolades go to them. They do the work, and I stand here and get your acknowledgement. Again, thank you so much for your time. I want to finish with a slide that you've already seen. And introduce Matt Williams. Now, Matt's a wonderful physiotherapist who I have the privilege to work with, who runs our osteoarthritis management program. So, Matt, thank you.
Thanks, David, and good afternoon, everyone. It's a pleasure to be involved today, and thanks to Lynn and David for coordinating all the speakers today as well. I've been very lucky the last 8 years since the OACCP, the Osteoarthritis Chronic Care Program's inception, to be able to collaborate with David and his team, where we've been able to come up with ideas and then test them and then publish them. And before I go into a little bit of detail about the OACCP, it's important to understand why the model of care was put in place in the first place. So traditionally, a patient would go to their GP complaining of hip and or knee pain. They'd be often diagnosed with osteoarthritis, prescribed appropriate medication, sent on their way with some advice potentially, find their way back at the GP, and basically the only direction they'd be turned to from there would be a specialist, often an orthopaedic specialist, and then often they would be offered some form of surgery. Now, unfortunately, for 70 to 80% of patients, this has been what's taking place, and those patients haven't been offered any evidence-based conservative management strategies until they've got to that point. So enter the OACCP, where patients are provided a coordinated care screening process. They're linked into care from a team of multidisciplinary health professionals that apply evidence-based intervention. They work very closely with each other and with the patients, and that patient's seen along a 9 to 12-month journey until they're able to get to a point where they're able to essentially self-manage their condition. The OACCP, in short, is an evidence-based integrated model of care which improves that interdisciplinary coordination of care for individuals with knee osteoarthritis and hip osteoarthritis. Our overarching goals are to reduce pain, improve function, improve quality of life. If we can, try and slow down disease progression, and ultimately, as I said, get those patients to a point where they can self-manage effectively. You'll notice that the patient is at the centre of the diagram there, and that's because what we deliver is all about patient-centred care. So we take into account what's important to the patients. We listen to them, what they value, what they're trying to achieve, and then we'll tailor our interventions in order for them to be able to achieve what they're trying, what's meaningful to them. Probably the best way to be able to depict that is through a case study. Bruce is a patient of mine I saw probably about 18 months ago, 53-year-old male then, he's 54 now. He had a 5-year history of right knee pain. It was getting rapidly worse over a 6-month period. Got referred over to our orthopaedic clinic, saw one of the orthopaedic surgeons who deemed that he was too young and also deemed that he hadn't had any relevant conservative management for his care. So I found him in front of myself. He'd had a knee arthroscope, largely unsuccessful. He has a number of concomitant comorbidities, hypertension, type 2 diabetes, sleep apnea. Sounds a bit familiar. And he also has obesity, which was getting worse every year. So every year he was putting on about 5 years because he was sedentary. He was a very keen golfer, but he'd had to give that away. He was also a very keen traveller. So we tailored our goals around getting him back on the golf course with his mates. And also he had a passion for Paris, and he wanted to be able to get over to Paris and be able to scale the steps of the Sacré-Cœur. And if anyone's been there, there's a lot of them. So we had our work cut out for us. So first he saw me. I spent a lot of time with him explaining what osteoarthritis was. There was a lot of myths and misconceptions that he had around osteoarthritis. There was a lot of damaging linguistics that made him very fearful to move and even put weight through his leg. You know, words like meniscus tears, bone on bone, degenerative this. Basically, a lot of the patients, like Bruce, get themselves to a point where they feel like the joint's going to crumble from under them. So I had to reassure him and say, look, there's a whole bunch of stuff you haven't done yet. Your muscles are as weak as jelly. You've got a whole bunch of weight to lose. There's some malalignment in your limb that we might be able to correct with a brace. Let's give that a go, because your joints are far more robust and far more responsive than you give them credit for. Let's try this and then we'll see how we go. So we got him on board, referred him to our wonderful team. Our rheumatologist, Shirley, gave him some more improved pain relief advice. Rosie, our dietitian, did a wonderful job in getting that weight off, as you'll see in a minute. He saw our wonderful orthotist team. I don't know if it was Kelly, Tom, Derek, who it was at the time. And we basically steered him through for the next 9 months, and he did particularly well. So very busy slide, but I'll talk you through it very quickly. His pain went from a 7 out of 10 to no pain at all when he was in the clinic with me. We do a couple of functional tests, getting in and out of a chair, walking up and down the hallway, and he halved his time, did even better than that. He lost 22 kilos of weight. He really got on board with the weight loss strategies and did remarkably well. Needed a new wardrobe with his waist circumference, and his blood chemistry, so looking at, particularly related to his diabetes, it had reduced remarkably as well. So 80% of his body weight gone. He was off all of his pain relief. Surgery wasn't even on the table. Halved his hypertensive meds. So, but what was most important to him and what actually meant anything to him really, he's back on that golf course. He's over at Gordon. He was able to play 9 holes. He's not in the cart. He's walking around with his mates. He made it to Sacré-Cœur. I wish I had a photo of him, but he managed to do a Rocky Balboa and got up the top of Sacré-Cœur. So it was fantastic. And this is my wonderful team. It's not all of them because, as I say, a big proportion of who we work with are the wonderful researchers as well. But thank you for your time.